I've been working in the field of sexual health and HIV medicine for about 17 years. I did my training in East London. I loved the intersection of general medicine, acute medicine, but then also sexual health medicine and treating people who got better very quickly. Suddenly overnight we had to break this culture of open access to really shutting the doors and paring down our service to essential services only. For sex workers, predominantly our Thai and Mandarin speakers, we had dedicated services for them which have been running for many, many years, serving the communities. But they had to stop work. Brothels were closed overnight. There was certainly a lot less foot traffic coming into the services. I'm not just talking about my service, but also allied sexual health services, publicly funded sexual health services, and perhaps high caseload general practices, which saw lots of presentations of sexual health or screening for sexual infections in gay and bisexual men have sex with men. But also, yes, I think generally there was a lot less sex happening during the lockdown period. That message was very clear, that it was dangerous to have casual hookups. I think a lot of researchers are looking at the rates of STIs that are taking place in the era of COVID, particularly in a COVID lockdown setting, where we know in London and in big cities like ourselves as well, where the presentations of symptomatic STIs definitely decreased. For example, the amount of presentations of urethral gonorrhea, so gonorrhea affecting someone with a penis, and discharge and pain, that decreased substantially. I think almost 80% reductions in those presentations to services, which suggests people were definitely not having as much sex. First principles are that we should be limiting the amount of close contact with people, and social distancing includes sexual activity. It becomes a very nuanced discussion about what is safe when you're having a casual hookup or with someone you know, and how do you make your own risk assessment that that person might not have a risk factor for COVID themselves. I think at the beginning of the pandemic, we were advising people not to have sex at all with anyone or any casual hookups, and it was very clear that people from overseas were the main risk. But now we have community transmission within Australia, and therefore knowing when someone has either visited a hotspot in New South Wales or Victoria, it's very hard to really check if you're looking at a casual hookup. And the nature of casual hookups is anonymous sex and occasionally very little discussion about those types of risks for COVID. We have initiated a number of changes which include innovative models of care, which is telehealth predominantly. PECS has been set up. It's web-based. The idea is that it generates a consultation room that someone can enter into, rather like they're in your waiting room. We know that there are challenges with these discussions. We're recognizing the consults are a lot shorter than they are when they're face-to-face. So we're recognizing that perhaps we are missing some critical information. We're also recognizing that patients perhaps are doing this when they're on the bus or not in a suitable situation for them for us to ask sensitive health questions. As a specialist sexual health service, we've always been looking at how we interact with GPs, and I think this new era of telehealth medicine and how populations are shifting between services or perhaps not accessing services is a really important issue. We're hearing from certainly population and community health that perhaps populations and people aren't coming in to see general practitioners, believing that they're closed or not really fully understanding that telehealth means that they're still open. And so we're interested to see how we can support GPs and refer patients from our services back to GP and vice versa. I think there are opportunities there to collaborate, and we're certainly looking at that. I don't think things will go back to normal. I think it's been a useful reflective process where services can think, well, can we do things better? Can we use technology better? But at the same time, recognizing that face-to-face has to be a big chunk of what we do. We need to ensure that our patients can access STI testing. There are other models suggested, such as home testing kits. I think what we are seeing now as the restrictions lifted was a move back to sex occurring again and hookups occurring, and that's reflecting in our activity again. Although it's still less than what it was. I think overall we're about 30% down in activity. I don't think there's been a time akin to this in our lifetimes. This is a unique public health situation.